Hello, everybody. Welcome to the United Leukodystrophy Foundation's virtual family conference session on AGS, presented by Dr. Vandiver. This session is being recorded and will be posted for viewing online in early July. Thank you so much for joining us. And now I will turn it over to Dr. Vandiver. Thank you.
Thank you. I think before I get started, since we have such a small group of participants, Tara, would it be helpful for families to raise their hands if they're patients or if they are other types of participants, just so I kind of know? Hi. Hi, Ms. Miller.
Well, you may feel free to turn on your camera if you feel comfortable.
Yeah, you don't have to, but just if people could sort of just put in the chat, just so I know, since we're such an intimate group, we can afford to make it a little bit more, right? Because am I right, Tara, that we only have like 4 or 5 people?
Yes.
Okay. Like I know
Five people if you exclude us.
Yeah, but David Isaacs is from our team.
Oh, okay. So yes.
Are you seeing anything in the chat? I can't see the chat easily with the way.
No, not yet.
Okay. Okay. Again, if I know that you're industry participants or family participants, I can tailor my talk
We do
accordingly.
have a medical student.
Okay. Is that coming up in the chat?
Yes.
Okay. Perfect. Okay, well, I'll do my best. And again, since we're such a small, intimate group, feel free to interrupt, right? I'm happy to make this a more interactive and talk and more of a conversation, given how small and intimate of a group we are. Sometimes if you're like 40 or 50 people, that's really hard. But with this small of a group of people, I think it's more than feasible. And Tara, you can help moderate if our group grows quite significantly, just letting me know that so that we can revert back to a more formal process. So I always like to make sure that everybody knows that we work broadly with our industry and family partners around developing treatment strategies for AGS, and that also we receive support from several both grant and federal and state grants for this work, and such that it's really a work of many and many supporters in particular. I don't take any personal compensation. And then in particular, I really want to thank the AGSA Family Foundation for their support, and also the support from innumerable ways from affected families, because really they are the ones who come and visit us and give all of their time and energies around helping us make some of this work a reality. I also want to extend my thanks to our clinical research team that you see on the left below. That's not a fully updated picture because we haven't been able to be like that in the lab since before COVID, but we'll take another picture as soon as circumstances allow. And then in particular, also Dr. Takanohashi, who is part of our bench research and biomarker team, Dr. Gavatzis and Dr. Adang, who are part of our clinical team and have worked a lot on outcome measures in AGS. So because I wasn't sure if there wouldn't be new families and families who were in search of a diagnosis, I put a section about how AGS is diagnosed. And I think even for those people who are just sort of more learning more about the disease in general, it's helpful to understand that most of the literature historically has focused on what's called the classical presentation of Aicardi-Goutieres syndrome. And here's an example of a typical case that was seen at our center with a 1-month-old boy who presented at birth with signs and symptoms concerning for congenital infection because of hepatitis, abnormalities in cell counts of the blood, and a smaller head size. At the time when that child was evaluated, The spinal fluid showed some elevated white count in the spinal fluid, suggestive of an infection, but also less typical for a standard infection. There was elevation of neopterin and tetrabiopterin. But when they looked at extensive viral studies, they were all negative. And ultimately, when the child developed more typical symptoms of extreme irritability and then some of the skin abnormalities, a diagnosis of AGS was made, in part based on the presence of calcifications on the imaging studies. And for a long time, that's how we thought about AGS. But more recently, we've realized that a not insubstantial proportion of children present slightly differently and will present later, sometimes after a year of age, with sometimes superimposed on a history of mild developmental delay. And then those children will present with more nonspecific symptoms, periods of recurrent fevers, periods of intermittent irritability, right? And then superimpose on that sort of period of time where things seem to be brewing, then we'll have an event where they present typically with a motor abnormality, right? That leads the patient to get a brain MRI, right? That typically will show white matter changes, sometimes also calcifications, but not always. And sometimes these children are misdiagnosed with something called ADEM, or acute disseminated encephalomyelitis, before ultimately the more progressive and recurrent nature of the symptoms lead people to think about primary genetic disorder, and appropriate testing may then be sent. And what that translates to is pretty significantly different symptoms, right? So you have some children who present with more profound motor abnormalities, and you can tell here this little girl is needing to be entirely supported, including her neck, by her father, who's playing with her, even though she's quite social and quite engaged. Then you have some children who are much more mildly affected and have good hand use and are able to sit and use devices to support their mobility. And then this little boy ultimately learned to walk unassisted. And so AGS does not have a single face and presentation. And that difference in clinical presentation is mirrored in many ways by the fact that there's diverse genetic etiologies. There's now a total of 9 genes that can cause AGS and AGS-like disease, with the important sort of commonality that in all these cases of these different genes, there's a commonality that the viral sensing mechanisms of the cell are triggered. So your body has very good ways of detecting extra nucleic acids that are different in their structure and their type than what's typically in the cell. And by nucleic acids, I mean things like DNA and RNA. And when they detect those, they respond with an immune response within the cell that's made by a special signaling molecule called interferon. And the cell then produces that interferon, and that interferon then is detected by other cells in the body. And together, in a normal circumstance, that generates an immune response to a virus like the flu. And people think that things like in the family of interferons are why you feel, achy and unwell, for example, when you have a significant viral infection. But in the case of AGS, there's an exaggerated and unchecked response, not to a virus, but by the body's own sort of failure to correctly interpret and manage its own DNA and RNA, right? And that in turn results in an exaggerated production of interferon, which ultimately injures a large number of cells within the body. And we know that nearly 100% of children children and young adults that we see with AGS have some degree of neurologic and brain involvement, but that beyond that brain involvement, there's also a host of other abnormalities. A not insubstantial proportion of patients will have abnormalities of their blood cells, including having low platelets, low white count, and low red count. And a more significant proportion will have problems with their skin intermittently. About a third of patients have problems with their skin, with inflammatory lesions of the skin that sometimes are not super specific and elude diagnosis. About 75% of affected people with AGS at some point in their life will have abnormalities of their liver enzyme, even though only a quarter of those have sort of more significant liver disease. A smaller number of patients will have problems with their endocrine system, in particular low thyroid, but sometimes also low growth hormone or different types of diabetes. Patients can have problems with their heart and the large blood vessels going into the lungs with something called pulmonary hypertension. People can have problems with muscle, with inflammation of the intestine, with something called glaucoma, which is a increased pressure because of decreased drainage of the fluids in the eye, sometimes problems with a joint inflammation, and sometimes problems with kidney disease. And altogether, it just points out how much the interferon is capable of injuring different tissues, and is something we need to be thoughtful about as we look to treat patients with AGS and understand how they might do over time. So, as people have thought a lot about treatment options within this group of genes and this disorder, and people have thought about, well, how can we minimize the effect of the interferon on all those many different cell types and tissues within the body, and how can we protect the body from injury related to interferon? So it turns out that when interferon is made by cells, right, this tiny molecule then connects to a receptor, right, and we've heard in the past, people may have heard in their biology class and stuff like that about how you have receptors on cells. Well, when a target molecule connects with a target receptor on a cell, it typically activates a bunch of proteins within the cell and creates sort of a cascade response. And in this case is an inflammatory cascade. And in the context of AGS, the important protein that allows that to happen is something called a Janus kinase. And once the Janus kinase is once the interferon is connected, the Janus kinase is activated, signals to a molecule called STAT, which then generates more interferon and other and production of other inflammatory proteins within the cell that can lead both to the injury of that particular cell as well as sort of the spread of inflammation throughout the body. Well, we increasingly are thinking about ways that we can interrupt that entire process. And it's important to remember that, whereas it might be hard, right, to interrupt, exactly the parts that produce that signaling, because, each one of the 9 different genes that causes AGS might have a slightly different reason and a slightly different part of the DNA and RNA that it doesn't regulate well. The interferon is sort of a commonality across all the different versions of AGS. It's also important to know that not all of the genes are equally common, right? So that the most common overall, at least in our sort of multinational cohort, there's some differences country by country, because in some places there's something called a founder mutation with one gene that's more often a problem. But in our sort of larger cohort, and this is based on about 200 individuals, the most common affected gene is RNase-H2B, right? With the next common TREX1, and these were some of the 2 earliest identified genes, so it's not totally surprising that they are more common, but fast catching up to them are additional genes, including in particular ADAR and IFIH1, that are increasingly being identified. There's 2 very new genes that were just published by Dr. Crow in the last couple months, right? That we do not yet have very many patients. They would show up as just a little tiny line here because they're just 1 or 2 people in our cohort. And it'll remains to be seen how big of a part this will play in the overall number of patients with AGS. It's also important to know that there probably are still additional genes beyond these 9, because on average, we have about 10% of our patients who look like they have AGS who don't have a particular genetic diagnosis yet. It's also important to know that amongst the different leukodystrophies, AGS is probably one of the most common. So if you ask the question, by asking all the large testing laboratories in the United States how commonly they find, a problem with an AGS-related gene in a patient versus a problem in a different gene that causes leukodystrophy. AGS is one of the most common ones. Now, it stands to reason that with 9 different genes, just from the perspective of how many genes are involved, that they might be more common. But it's important to know that other leukodystrophies, including some of the peroxisomal biogenesis disorders that have like 20 plus genes, and also other genes that have 5 or 3 or more genes, still might not have as many patients as AGS. So it's certainly not amongst the rare disorders of the leukodystrophies an infrequent disorder. So back to sort of diagnosis and the way we think about it. In our case, we think about both the clinical history, right? Certain tests like the CSF spinal fluid and the genes before we think about a diagnosis of AGS. Importantly, in the future, we hope that children with AGS will be diagnosed earlier and sooner. And one way of diagnosing people early and specifically before, the onset of a lot of neurologic problems would be by doing newborn screening. And there is some hope, although we're certainly not yet at the point of a pilot or implementation of newborn screening for this disorder. There's some hope that it might be possible to do newborn screening, because when we look at expression of interferon genes in blood spots that are taken from newborns who have AGS, we know that we can actually identify abnormalities of that interferon signaling from birth, even if in some cases, the presentation of the disease, or when patients actually became clearly sick from the disease, might not occur for years, right? Those patients, there's still a proportion of patients, about a little bit less than 25%, right, who don't have elevated interferon scores at birth. And those are the same patients who really don't have elevated scores at any point in their life, because in our SH2B patients, we sometimes don't see elevated scores. So there'll be more work in this area, but there is, again, some hope that we might be able to identify these children early on before disease onset. And also importantly, an important advance in the leukodystrophies has been newborn screening for a disorder called adrenoleukodystrophy, or ALD. And it turns out that the same molecule that's used to detect a newborn with ALD, which is 26-liso-PC, is also elevated in children, in some cases with Aicardi-Gouttières syndrome. And there have been a number of patients who have been identified that way. That doesn't mean that these children also have, in addition to AGS, adrenoleukodystrophy. It just means that the inflammation that is caused by the AGS actually disrupts a particular part of the cell called the peroxisomes, and that presumably leads to a finding of some of those elevated lipids that are known to be abnormal at much higher levels in children with adrenoleukodystrophy. So there are already some children being identified based on newborn screening at this time, accidentally through ALD newborn screening. The other thing to keep in mind is that we sometimes see patients identified and even have genetic findings consistent with AGS, but the doctors who care for those children are not sure that they actually have AGS because they don't fit the typical sort of early presentation that has been described in the past in the literature. And so increasingly, we're identifying children with a later age of onset. And you can see that in particular, some of the more recently identified genes, including ADAR and IFIH1, are more likely to have a presentation beyond, and sometimes well beyond, 1 year of age, and more likely to be late in onset relative to the genes that were identified early on, including TREX1, RNASH2B, and SAMHD1, that were much more likely to present before a year of age. Often, in those children who present later with neurologic findings, if you really look back with a careful look at how they were doing before 1 year of age, you often realize that there were some differences in how they were doing well before they started having clear neurologic symptoms. And sometimes those symptoms are mild developmental delay, and sometimes they're more overt with things like recurrent fevers and skin abnormalities and clear inflammatory symptoms that occur in the months and weeks right before they present with precipitous neurologic changes. Again, in that early phase, some patients have the most patients who present late have developmental delay, but they're in the months and weeks before, patients who have unexplained fatigue, chilblains, which is a special skin problem, unexplained febrile illnesses, and just overall irritability and grouchiness. And then when they start getting more overtly sick, they start having differences in tone, they start having loss of motor milestones and changes in their communication abilities, as well as sometimes very clear symptoms like hepatitis or white blood cell involvement. There are differences between the different genes with how we expect children to do as far as over time gaining developmental milestones. And you can see that one of the first genes identified, the TREX1, those children are much more likely to have a very hard time with their development overall, with the most sort of consistently achieved milestone being things like gaining head control or rolling, versus some of the more recently identified genes like ADAR and IFIH1, right, and even SAMHD1, being more likely to allow us to see acquisition of milestones such as walking by yourself or even walking upstairs. And so overall, if you look sort of at like a heat map, right, of AGS, it's clear that, AGS overall remains a severe disease with the most consistently acquired milestone in, more than 90% of patients being smiling, right, with the warmer colors here being when more people are achieving the milestone. But within that group, TREX1 is patients with TREX1 are more likely to have a very significantly hard time. Patients with ADAR and IFIH1 and SAMHD1 being more likely to gain more milestones, including complicated ones like language and walking up steps, and then RNASH2B being somewhere in the middle. And the other thing is that the greatest amount of change, the greatest amount of either worsening or improvement seems to happen within the first, 6 to 12 months, right, of since disease onset. And you're going to be seeing much less change in developmental skills the further out you get from a diagnosis, such that after several years, although the disease can continue to worsen, it is more likely that it remains more stable from a neurologic perspective, even though there can be significant problems with the liver, the skin, or the white and red blood cells in the future months. Now, the difficult thing about that is that you could argue that children who have little left to lose because they've already lost a lot of developmental milestones might therefore be less likely to have a great amount of movement and loss in developmental milestones. But I do think it's just sort of important to think about the fact that they're also less likely to have significant improvements. So around these sort of multi-system problems, we now have developed sort of guidance around the things that doctors should look for and watch in children who are affected by AGS. And specifically, we've made a bunch of recommendations, and those are things that we do for children that we follow at our institution. We recommend that children be monitored carefully for complications in the blood counts, because those problems, although often occurring early on in disease, can actually crop up in an unexpected way throughout the lifespan. We also recommend that people have annual liver enzymes through blood test, because people can equally also develop hepatitis over time. Because some children have progressive heart disease, we recommend that they have an annual or biannual, depending a little bit on their specific disease type, study of the heart, including echocardiogram and EKG, because we know that some children can have abnormalities with their valves, can have abnormalities with the heart muscle called cardiomyopathy, or can have abnormalities with the pressure in the large vessels of the lungs called pulmonary hypertension. For those children who have SAMHD1, because they can get problems with the large blood vessels in the brain, we recommend an annual MRA with MRI, because a lot of children can have really significant problems with inflammation of the gums. We recommend frequent, at least every 6 months, but potentially every 3 to 4 months, dental examinations and cleaning to minimize sort of those issues with dental loss that we see in some patients, right? We also recommend that children have daily skin monitoring by their parents, and that their parents feel empowered to bring to medical attention any significant skin changes. Recommend that patients be followed by blood work to make sure they don't have thyroid problems, and also that if they have symptoms consistent with diabetes, they be evaluated rapidly for them. We worry that patients may also develop progressive renal problems, and so we recommend that urine analysis and special blood work for kidney function be done. And we also worry about growth and differences in bone, and recommend that bone age and growth hormone surrogates be checked. And then finally, we recommend at least every 6 months a neurologic examination, just because the abnormalities seen in AGS can be complex and can include not only manifestations from injury from the brain, but also problems with myopathy and nerve problems, or called a neuropathy, which can impact how someone's functioning and how best to manage tone problems and functional disabilities. Finally, patients should have at least an annual eye exam with specific intention to actually looking for glaucoma by measuring the pressures of the eyes. Not all pediatric ophthalmologists routinely do that for pediatric patients, because glaucoma is a fairly infrequent complication of AGS. So in a summary, we ask that physicians caring for children with neurologic disabilities consider AGS in children with neurologic problems, as well as evidence of abnormalities in the skin, the liver, or the blood count, in particular if they have sort of an overall feeling of inflammatory changes, including recurrent and unexplained fevers, and a constellation of other symptoms. We also recommend that AGS be considered in newborns where there's concern for congenital infections, or newborns who screen positive for ALD without having some of the follow-up confirmatory lab studies that is consistent with ALD. And then also considering AGS in older infants and young toddlers with an onset after a period of either previous systemic inflammation or developmental delay of loss of milestones. So that's sort of the end of the first part of my talk. I don't know if there's any sort of specific questions about this section before I move on to some of the aspects around the treatment of AGS.
You must be very thorough.
I can't see. Yeah, I can't see any comments, anything in the chat. So feel free to let me know if anything comes up, or if anybody's raising their hand.
Will do. We have a quiet group today.
Okay. So I'm next going to move on.
Evelyn, this is Keith here. Maybe I'll jump in with one quick question. But how are you standardizing? Are you using any Epic Help list to make sure or certain checklists to make sure all these tests are
Yeah.
done? for the
Yeah,
patient?
we have,
Because
we
it's
have
a great
actually
setup for it. Yeah.
Yeah, we actually have Epic order sets. And we also have dot phrases with like tables that
Right.
helps us keep track of when children had their last cardiac evaluations and other things. I'd be happy to share in particular those dot phrases. I think are pretty easy to share. I'd be happy to share those dot
Mhm.
phrases with you, Keith, if that's helpful.
Sure. Yeah. I mean, I think that's but sure. Be happy to take
Yeah.
those. But that's
Um,
nice. Thank you. Appreciate that.
We do have a question in the chat. It says, can you explain a little more about the two new genes? What do the names mean and what do they do?
Yeah, those are histone deacetylases, right? Sorry. So, the different other genes, right, each regulate a certain part of how your DNA is sensed, right? So, for example, TREX1 cleans up DNA that's by itself without being a double helix. IFIH1 manages sort of how you recognize and how you tag double-stranded RNA or RNA that's supposed to be by itself. So DNA is supposed to be two pieces together. RNA is supposed to be one piece by itself. The IFIH1 changes how you recognize RNA that should be tagged because it's two pieces. ADAR1 helps clean up RNA that is two pieces, and then the RNase H's clean up pieces where it's RNA and DNA combined together, which is not supposed to sort of stick around in the cell for very long. The histone deacetylases, which are the LSM11 and RNU71, right, which are just they have to do with sort of, I'm not sure that it's so helpful to know the exact terminology of the names, but they have to do with histone deacetylases that help normally keep the DNA wrapped appropriately with itself, right, and unwrapped appropriately. And those things also have to do with how much the DNA and RNA is sensed within the cell. The DNA in this perspective is sensed within the cell and detectable by these techniques that are supposed to recognize pieces of viral DNA and RNA within the cell. And the important thing about the RNU71, interestingly enough, is that it's not picked up easily by the standard types of genetic tests because it's what's called non-coding DNA and really lives in the cell as an RNA. And so you need special techniques to pick that up, including things like whole genome sequencing. And so we're right now looking back at our cohort of children who have unsolved AGS to try to see if how many of them may have actually abnormalities in those two new genes. I hope that answers that question adequately. Any other questions, Tara?
It looks like that was it.
Okay. I'd like to talk now a little bit because I think families who have not seen us at CHOP in sort of the recent past might have a lot of questions about some recent experience around a medication that we borrowed from the rheumatology world to try to treat AGS. And just as a reminder to go back to this sort of like concept of the interferon receptor, right? The interferon, when it connects to the receptor, activates this thing called the Janus kinase, right? And we know that once the Janus kinase is activated, that it creates a series of cascading events within the cell that perpetuates and cause inflammation within that cell and can cause a lot of cell injury. Well, it turns out that this process is probably also important to other more common adult diseases like rheumatoid arthritis and psoriasis. And so drug companies have used ways to sort of block that Janus kinase that gets activated otherwise when the interferon connects with the receptor. And what happens when that's blocked is that then even though the interferon connects with the receptor, it doesn't actually cause any downstream effects within the cell, and theoretically could protect the cell from the effects of the interferon. So what we did is we borrowed one of those medications called baricitinib as it was being developed by the drug company, and we treated 35 patients as part of a study while the medication was really being developed and proven for things like rheumatoid arthritis. Now that medication is now since been approved for treatment of rheumatoid arthritis and psoriasis, and so that medication is commercially available and people are now starting to use it and prescribe it. But what we did, we went before that was done and sort of looked at how that could help children with AGS. So the children, had a mean age of onset of 0.8 years. So most of these children were sort of in that severely affected group, right? But the children were treated with a mean age of 5.9 years and sometimes more than a decade. And so, the important thing to remember is that just like we told you, normally we would expect those children who were more than 6 to 12 months out from having disease onset, you wouldn't expect anybody to get very much better without any intervention. A majority of these children were male for reasons we don't understand. There are more affected children with AGS who are boys than girls. And otherwise, the different genes, excluding the two more recently identified genes, because we didn't even know about these genes when we started this trial. Otherwise, the different genes were all represented within the cohort. And then finally, children were treated by the time we did the analysis for at least approximately a year and sometimes upwards of several years while on medication. So there are a couple of things that we followed in the patients while they were treated. And it's important to know that this is not what's called a randomized controlled trial. It's not like we gave medication to some people and didn't give medication to other people. Everybody got medication. And while that might sound great from the perspective of, if you were that child's family or that person, that you would want to know that you were getting, the medication and not a placebo, it does make it harder to show, right, that the medication works. But what's important to know is that we looked at patients, right, over time, and we looked at them from before they were on the medication, and then we compared how they did after the medication. And so to some degree, we tried at least to show that the patients with themselves is their own control, right? So we asked families, and parents did this, for months and years, to every day fill out a diary showing sort of how they were feeling while they were on the medication. And that diary encompassed things like crying and poor sleep and just general irritability. And then also things like seizures and fever and skin findings. And overall, people seem to feel better while on the medication when our statisticians looked at the data over time. We also looked at something called the interferon signaling gene score, which is basically a measure of the amount of you remember I explained that once the interferon connects with the interferon receptor, it causes a cascade of events within the cell. Well, that cascade of events is determined by a series of genes called interferon signaling genes, and you can actually measure the amount of expression of those genes within the cell. And so we measured how much interferon signaling there was going on in people's bloodstreams. And we noticed that almost right away after we started the medication, within a couple of days, the amount of interferon signaling within the cells came down quite a bit. Then it often, on average, re-increased. And so when you look at this heat map, you can see that overall, right, the right side, while they're on study, is cooler, right, than while they're off study. But you can see that there's still times where the scores are very high, right? And that's because when patients had, other events in their life, they were not well for some reason or had another immune trigger, they could still have a high interferon, right? But sort of what the medication seemed to do is decrease the thermostat a little bit to make everything just a little bit cooler. We also know that children, and this was visible to the families as well as ourselves, that children who had skin involvement, their skin appeared overall better, right? Now, not everybody skin got better between the beginning of the study and while on study, in part because skin manifestations in AGS fluctuate and they can get particularly worse in winter months. So if you started medication in June and then you were reevaluated in December, you might not look a lot. You might look worse actually than you did in June. We didn't have a way to capture whether or not people looked better than they would have another December, of course. But overall, we had a proportion of patients who had significant skin inflammation, and I'm showing here 3 examples, whose skin got a lot better while on the medication. And in particular, in this little baby, we at some point decided to decrease the dose of medication because of some unrelated complications, and the skin got worse again. So we really do think that that the medication does help control the skin problems. What was most surprising to us is when we looked at a series of developmental skills, things like holding your head up well, or cooing, or using words, or using a pincer grasp, or moving around by rolling or by standing and walking, right? When we looked at those developmental skills and we looked at children for the months and years before they were on medication, patients were almost irreversibly either stable or actually getting worse, right? With some rare exceptions. But when we looked at patients after we started the medication, the year after, we saw a proportion of patients actually have an improvement in developmental skills. Now, I don't want to oversell this, right? This isn't sort of a Lazarus effect, but you have children who were gaining 1 or 2 or more developmental skills, such as vocalization, such as single words, such as word combinations, such as better head control, such as sitting, such as moving to better supported walking and things like that, in ways that we would not have expected before the treatment. So that before the treatment, most patients were either stable or somewhat worsening, with a minority achieving a gain of 1 or sometimes 2 milestones. But after treatment, children were more likely to be gaining some milestones. And we felt even more compelled by that when we realized that if you were getting as much medication as you could ideally get, and some patients were not for various reasons, sometimes because we were having to watch blood cells very carefully and things like that, and we felt uncomfortable pushing the dose of medication up. But if you were really sort of maximizing the amount of medication you could get, you were more likely to have more gains in milestones, suggesting that it's really likely that that may be due to the medication, not just due to random chance. So an important thing with this class of medication is that these medications are not without side effects. So, the Janus kinase is also important for a number of different other body functions, including the growth hormone and some things related to blood cells. And particularly interferon is important to your protective mechanisms around infection. And so we were very careful and thoughtful about potential side effects, and continue to watch children who are on this medication, even when they're now off study, very carefully for a number of things. One, we monitor them really quite carefully for infections. And there's a series of things that we need to check before. We also monitor children for differences in their blood counts, and I'll talk a little bit more about that later. We monitor children for differences in their liver tests, and we monitor children for differences in muscle enzyme. And overwhelmingly, the most consistent difference was that patients had more elevated platelets, which is a known and expected side effect of the medication, slight decreases in red and white blood cell counts, right? Which obviously we monitor carefully for increasing the risk for infection. Liver tests actually improved on the medication. And then rare patients had differences in muscle enzymes, which we think were unrelated to the medication because people had gotten things like Botox and things like that before. So what does all this mean for using this medication clinically now that this medication is commercially available? And I want to emphasize this medication is not approved in AGS. The FDA has not granted approval for AGS, but that this medication is available commercially, and so that physicians can prescribe it on a based on what's called a compassionate or off-label use if your physicians are are comfortable doing that. So, it's also the question people's doctors ask me all the time is, well, which patients are going to benefit? And that's something we really don't know the answer to yet. It's important to remember that a small overall numbers of patients have been studied, right? That some patients have experienced benefit even after many years of disease progression, but that it might be reasonable to emphasize children with more recent disease onset or significant inflammatory symptoms, right? Because it's probably more likely that they'll clearly benefit from the treatment. And then it's also important to keep in mind that we exercise caution around patients with significant history of infectious or hematologic abnormalities, right? We also, are thoughtful just from the way you can dose the medication. Until liquid formulations of medication are available, it's going to be hard to dose really tiny little babies, right? It's also important probably not to treat people who have a history of abnormal blood counts, risk factors for clots, or abnormal kidney function, because all of those might limit how much you're able to dose effectively the medication, because those are known side effects. We do extensive blood work before children are started on medication to make sure that we really understand how the AGS is affecting the body and know sort of where we're starting from as far as complications. We also really look carefully for any evidence of existing infections that might get worse during treatment, and look carefully at how your kidneys are functioning and how your blood lipids are, because we also know that the medication can change blood lipids. We make sure that people are not taking lots of other medications that might suppress their immune system, including steroids. We continue to monitor blood counts and other ways of looking at the immune system every couple of months during treatment. And we look carefully at other blood complications. It's always important when you try to look at modulating the immune system to keep in mind that the immune system protects you against cancer. There's not been really a clear increased risk of cancer in basically more than 100,000 adults now who've taken this medication, but we're still thoughtful about it, and we tell families about that. And then also there's a risk in grown-ups that may be unrelated to the medication, but may actually be related to the disease, but it's really not known, of getting blood clots. And so we ask people to think carefully about that as well if they're deciding to treat a patient who's had a history of blood clots in the past. We also look, we follow patients carefully for problems with liver. Some patients have some stomachache and nausea when we first start the medication. And then we also counsel patients that they really shouldn't take high doses of aspirin-like medications, because in grown-ups who take high dose of aspirin-like medications and baricitinib, there's been reports of people getting stomach and intestinal tears. We follow cholesterol levels, and sometimes we refer patients to cardiologists for management of cholesterol lipids. And cholesterol and blood lipids, because we know that can sometimes be abnormal in people taking baricitinib, and we don't want to, increase the risk for other long-term health complications because people are taking this group of medications. And then there's not as much data as we wish on treating young pediatric patients, and so one thing that's sort of an open question still is how and if medications like baricitinib might affect bone growth, because we know it can affect things like the growth hormone receptor. And so we ask people to be carefully followed also from a bone health perspective. And then, it's really important to keep an eye on how the kidneys are functioning. We think that the kidneys might not always function really well in AGS, and this medication is a medication that's cleared by the kidneys. And so it's particularly important to understand how the kidney is functioning. And then finally, for those individuals who might be in a position to become pregnant or breastfeed, this is a medication that's not considered safe during pregnancy and breastfeeding. And so it's recommended that contraception be used if you're treated with this medication, and that there's regular testing for pregnancy.
We do have a question in the chat.
Yeah.
It is this treatment available to those, is this treatment available to adults with AGS? Can those patients still contact CHOP, or is there a provider for adults we should connect them to?
Yeah, that's a great question. We do treat grown-ups with AGS as well. we don't have so much an age barrier, as we want to make sure that we're not putting people to undue amounts of expense and sort of overall burden for traveling to CHOP, because CHOP is on one side of the United States and you might live on the West Coast. And so it's fine to contact CHOP, and then we can help sort out from there what might be the best option for you, depending on sort of your geography and your individual circumstance. Grown-ups taking baricitinib gained sometimes some weight, and we did have some grown-ups with AGS who took baricitinib who complained about weight gain. So that's an important thing to keep in mind and to watch for. And then, there were cases, not so much in our patients, but in grown-ups taking baricitinib for other causes who had problems with allergic reactions or acne. And or headache, but those things were considered pretty minor, unless you had a really bad allergic reaction, of course, but you would know pretty quickly, and not necessarily a reason not to take the medication. So it's important also to know that the thing that I lose the most sleep over for my patients on baricitinib is infections, right? In the hundreds of thousands or so of grown-ups taking this class of medication, people are more likely to get colds, people are more likely to get urinary tract infections, people are more likely to get cold sores and reactivation of the chickenpox virus called shingles, right? And then also some unusual and serious infections have occurred, right? It's also important that we think a lot about whether or not some viruses, like the virus for mononucleosis, the virus for cold sores, and the virus for chickenpox, might be reactivated because your immune system is not monitoring for them as well. Those viruses that I've listed there, ABV, CMV, HSV, and VZV, are ones that once you've had them, they live within your body forever, right? And you might be less able to control them if you take this class of medications, and those are things to watch for. So we actually test people to see if they've seen those viruses before. It's also important to know that people should absolutely not get live vaccines if they're on this medication, including vaccine for shingles or chickenpox, or the vaccine for measles, mumps, and rubella. And when baricitinib is administered to children who have not yet completed, my text fell off there, all their vaccinations, we talk carefully to families about what that means for them and how we should interpret things. There's also a virus that most of you, and even I, had never heard of until I started using this medication, which is a virus that, just like the chickenpox virus, sort of lives in you. It's called the BK virus. It lives in your kidneys. And when people have any degree of kidney problem, we monitor for that virus as well in their kidneys. All right.
There is another question in the chat as well.
Yeah.
It says, for AGS kids not on the drug, I can't say it right. You talk about how AGS kids can have low RBC and low WBC. Can anything be done to help with the anemia?
Yeah.
There's more to it, but I can continue after.
Go ahead. Yeah, go ahead.
And is this why my kids have a sepsis with normal WBC until they get really, really sick? We get sent home from the ER repeatedly due to normal WBC and are back in a day or two, even going back once or twice before WBC goes up, and then they get admitted. What should I do when I think they are sick, but the ER sends us home repeatedly?
So that's a great question. There's a lot that we don't fully understand about the immune system in AGS, aside from when you mess with the immune system for treatment of AGS, like with baricitinib, but just at baseline. And increasingly we think about AGS as a disorder of immune dysregulation, right? And where even if some of the blood cells are there, they might not be doing their job quite right. And so I think it might make sense if your child has had repeat infections that have required hospitalization, right? That you potentially talk to your doctors, your pediatrician or your complex care pediatrician, your neurologist, about seeing an immunologist, right? And an immunologist who might help you formulate a plan for what, how to respond to infections in your child and what might be going on with the immune system in your child. And then write an emergency letter, right? That you can bring with you to the emergency room to say, the typical rules don't apply because, right? Of AGS, and because what we know about this particular child, to help you around that issue? Because that sounds like something that an immunologist and your pediatrician or complex care pediatrician might be able to help you with. I hope that's helpful advice. Tara, is it okay if I continue? So one thing I do want to mention
Sorry, I lost connection. I apologize. Yes, you can continue.
Perfect. One thing I do want to mention is that we don't yet know really, if we start baricitinib on a patient, does that mean it's lifelong treatment? We don't really know. We typically are using this medication when children are, doing very poorly. And then at some point, if they're doing better, the question becomes like, can they come off the medication? And, we've been careful about that. And we have taken some children off of medication very slowly and gradually with no adverse effects, right? But we also have taken some children off medication more rapidly, especially if there was concern around infection and people were worried that maybe the baricitinib was making infection worse, and then had children have a harder time and actually do worse. And there's in particular one child where we interrupted the medication for a period of days while they were sick, and then they, had changes in their motor function that didn't really come back. And so what we also don't fully know is if you start medication early, can you fully prevent episodes from happening? And I think we don't really know the answer to that question yet. We do have a couple of siblings, right, where the children who were treated earlier because they were the younger siblings of patients who were previously known to have AGS seem to do better than their brothers or sisters, but we don't really know long term, if we were able to detect everybody at birth and treat children, would it really prevent neurologic injury? So in conclusion, right, I think the most important thing, other than that baricitinib is tolerated in AGS, but needs to be done in very careful hands with somebody really thinking about any side effects, right? But I think the most important thing is that baricitinib has offered us the hope that actually AGS is a treatable disease, and that it's even treatable disease, after sometimes many months of disease and sometimes significant loss of neurologic function. So that brings us to sort of what does the future hold for the treatment of AGS? And I think it's important to remember that there are a lot of different pressure points within this system that we might be able to weigh on to make the course of AGS different, right? So specifically, it might be possible to not just block the interferon from connecting with the interferon receptor, but actually block the production of interferon by interfering with how the cell senses DNA and RNA within the cell. And there are some people who are working on those kind of treatments. There's also other ways of blocking the interferon receptor, right? Not through the Janus kinase inhibitor, blocking the receptor itself through antibodies, other ways. And then there might also be better ways of getting better effect in different affected organs, particularly the brain. The brain is particularly well protected from medications through something called the blood-brain barrier. And it might be that there are ways of actually getting into the brain more efficiently with medications or with other approaches that can be considered. In the short term, these treatments are going to prevent additional injury and allow recovery, but probably not rebuild brain tissue that's irreversibly hurt. Things like cell-based therapies and things to replace structures within the brain are still largely in the future. However, as we develop additional treatment approaches, newborn screening is going to become increasingly important to better understand both how the disease will progress if you treat, but also to prevent and improve neurologic outcomes. And so I think I want to end on a hopeful note that, I think AGS is a treatable condition. We already have some treatments, although they're not entirely benign and need to be done in very careful hands, and that the future is encouraging. And I'm sorry, because I meant to leave more time for questions. And I know we're sort of constrained about not necessarily being able to continue past the hour. I don't know if the fact that we're towards the end of the day gives us a little bit more room, Tara.
Yeah, we can extend it a couple minutes. I do see there is another
Okay.
chat. It said
Let
my
me
son,
try to stop my screen share so that
oh,
I
okay.
can,
So that you can see it.
well, so I can see things. Give me a second.
No problem.
I can't even figure this out. Okay. There we go. Stop share. Okay.
If you hit the chat.
The chat.
Yeah.
Yeah. So the issue with recurrent UTIs is really hard, right? Because children with AGS have problems with their tone that makes the bladder empty less well, and can also have problems with constipation that also makes the bladder empty less well. And so it's not unusual to see really significant recurrent UTIs. So I don't think that I don't know about treatments with bacteriophages. So I don't know a lot about it, but I think if it were being administered through the bladder, it would not probably increase risk. Because I think that children with AGS actually respond well to a lot of viruses, and families have often said that their children don't get as sick with viruses. And so I think that probably would be okay to try, but I don't know very much about it. And then someone asked about a plan for a family meeting in Philadelphia. We're going to start with a virtual meeting, hopefully, still in 2021, right? In part to think about and plan for additional clinical trials. And then we're hoping in 2022 that we might be in a position to plan for a family meeting. We would have had another family meeting in person sooner if it hadn't been for COVID-19 and all the complications associated with that. And for anybody who's not sort of already enrolled in our registry, if you want to reach out to us for information, I'll just put our email here.
Okay, are there any additional questions?
I can't actually, I'm stuck in not being able to reply to the chat, but otherwise, you can look me up on the internet. I'm very easy to find. You can always connect us.
Yes, and you can always, if there's any questions not addressed in the session, you can email them to office@ulf.org and we can always pass them along. But people are saying thank you for helping our kids. But if there's no further questions, I just want to thank you again, Dr. Vandiver, and our sponsors, and of course our audience for making the virtual family conference this year a possibility. We hope to see you in person next year. So thank you very much.
Goodbye, everybody.
Bye.